Morning. How are you guys? This topic was assigned to me, the bacterial pneumonia, and I think it's important to go over this. I tried not to go over guidelines and things that you probably all know, but there are some important things that I'm trying to cover here. So let's start. Now, pneumonia is a big problem, of course. It has a lot of admissions, a lot of mortality. If you can see here, the true incidence is not well known because it is not a reportable disease. And there are like more than 500,000 admissions per year, 2 to 3 million deaths a year. Although this is approximate number. Patients who require hospitalization, their mortality is 5 to 15%. Those who require ICU admission is 20 to 50%. However, those who are treated on outpatient base, it is less than 1%. It is the most frequent fatal nosocomial infection, and it's the second most common nosocomial infection after UTI. And it is the 8th leading cause of death. So it's a very important topic. Main question is, why do patients get pneumonia? And I was asked this question when I was a first-year resident. And my answer was because we inhale a virulent or pathogenic bug. And that is not the best answer. The best answer is microaspirations. That is the most common form of pneumonia. So there are 3 reasons why we get pneumonia. Microaspirations, which is the patients you see almost every day, and macroaspirations, and less likely patients who get some pneumonia by inhalation, like mycoplasma or Coxiella or Legionella or these atypicals or TB. But how often we see those? Not that often. So, like I said, most important thing is aspiration of the oropharyngeal secretions. Oops.
Dr. Al Shathir.
Yes, sir.
A very good question from the peanut gallery. Could you talk a little bit about the infectious nature of pneumonia? Just regular community-acquired pneumonia. And the patient coughs on you, or you're in the room with the patient. What's the likelihood that that's transmissible, that you can actually catch that?
Not very common, because here is the catch. Someone who had regular bacterial pneumonia, he coughs on you, he has to change your mouth flora, and then you have to aspirate and get the pneumonia. So it is multiple steps. So really, droplet isolation doesn't change much in regular bacterial pneumonia. It may change in something like TB or something that can communicate by aerosolized material, you see, but not regular bacterial pneumonia. And that is really the concept of this introduction. Now, 50% of normal people aspirate at night. Usually, they don't aspirate during the day. Now, 1 in thousands of a mil contain more than 100,000 bug. And we are talking about normal individual, not someone who's a smoker or alcoholic or had tooth abscess or something, which it might be even more. So just a little bit of material can introduce some bugs to your respiratory tract, okay? Now the other issue is the use of broad-spectrum antibiotic is not safe because of this concept. You use broad-spectrum antibiotic. Now, why people who use broad-spectrum antibiotic are at more risk of having pneumonia? You use this antibiotic, and then you kill the sensitive bugs, and then you will be left with the more virulent ones. And then when you aspirate, you will be at risk of pneumonia. And I will tell you this story. This is my daughter. This was last year. She's a very healthy kid. She never used antibiotic prior to this incidence. She developed tonsillitis, and there was pus in it, and it was nasty. So I gave her amoxicillin. She did well. 5 days later, she was fine. Then 2 days after she completely recovered, she developed UTI. So I was surprised. I mean, why 2 infections in the same week, basically? So I gave her at this time Bactrim. She didn't get better. And this picture was in the urgent care, so we tried to do some urine analysis and culture. And she selected a very nasty bug. It was resistant to almost everything that a kid can take orally, except third-generation cephalosporin. So that's why, I mean, really the problem is the microflora in the mouth that causes the pneumonia. So basically, oropharyngeal colonization depends in part on the interaction of microbial adhesion molecules with the cellular receptors or matrix protein. So for example, the most common one is strep pneumonia can bind to platelet activating factor receptor on the epithelial cells. And these receptors or this binding get upregulated by smoking or by viral infection or air pollutions. So that's another reason why those people are at more risk of pneumonia, because of this interaction. Now, what about macroaspiration? Macroaspiration is, so basically what I'm trying to deliver in this first section is all community-acquired pneumonia and most of hospital-acquired pneumonia. In fact, it's microaspiration pneumonia. Now, what about macroaspiration pneumonia? When you aspirate just large quantity, where you have less virulent microorganism, but in large quantities. And this is where we get the usual anaerobic infections. Now, anaerobic bugs are not as virulent, and it is not easy to culture and identify. But if they get into the respiratory tract in large quantities, they cause necrosis, and eventually you end up with abscess and chronic infections and its complications. So there are 4 different presentations of macroaspiration. The first one is aspiration pneumonitis. And in this scenario, the patient will develop fever, cough, dyspnea, plus minus pleuritic chest pain. However, there is no hemoptysis. Usually there is no foul smell in the sputum. And usually there is no lobar consolidation. They can have like bronchopneumonia type of picture rather than lobar pneumonia. And usually it involves the aspiration-prone segments. So what are the aspiration-prone segments in the lung? So it is the superior segment of the right lower lobe and the posterior segment of the right upper lobe and the corresponding segments on the left. It's usually on the right, and it's usually involve the posterior segments, because usually the patient is flat when this happens. However, it can happen anywhere. It depends on the position of the patient. Now, the regular aspiration pneumonia that we tend to see in the hospital, there is no way to differentiate it from regular community-acquired pneumonia or healthcare-associated pneumonia based on radiology. You have to think of the chronological order of events, like he's having pneumonia and like a month later he's having pneumonia, or something of that sort, in different places. If it is in the same place, you think of post-obstructive pneumonia or some endobronchial lesion. But if it is in different lobes within short period of time, you start thinking, am I dealing with aspiration pneumonia? In the regular aspiration pneumonia, the specific lobes is less distinct. So that's why it is hard to tell. Not like aspiration pneumonitis, because it takes time for the infection to cook. So it might involve different lobes or different areas. The third scenario is anaerobic pleuropneumonia. So this is probably you saw this X-ray before from the X-ray lectures. This is an alcoholic guy who had frequent intoxications. So he comes to you with a chronically ill status, like he had several weeks of being ill, fever, cough, sputum, foul smell. What happened is they aspirate on a frequent basis. They start having small abscesses or cavitary lesions, not necessarily abscesses, less than 2 centimeters. And then these tend to coalesce and form an abscess. Okay? So this is less acute because the organism, the anaerobic organism or the mixed infection is usually less virulent. So it takes time for their representation. Okay? So this is the third scenario. And then the fourth scenario, which I didn't mention here, is when you have anaerobic empyema, which is outside the topic of this lecture. But you don't have pneumonia, but because of this aspiration or from other source, like from abdominal source or whatever, you have anaerobic empyema. Okay. Bacteriology of hospitalized patients with community-acquired pneumonia. The most common organism, of course, strep pneumonia. Now, if you don't know the answer and you are asked about the most common organism of anything, probably the answer will be strep pneumonia. However, in young adults and older children, like above 2 years old, the incidence of mycoplasma pneumonia is higher. That doesn't mean in older adults this incidence is less. It just means in older people and infants, they are at more risk of strep pneumonia. But really, in every other setting, like if they ask you about what is the most common organism in healthcare-associated pneumonia, in ventilator-associated pneumonia, in any form of pneumonia, the answer will be strep pneumonia. Now this, I think it's important to review before any board exam, just in case they ask you about microbiology and some key points in the question that tend to give you the diagnosis. So if you have someone who's alcoholic, again, strep pneumonia, anaerobic infection, and the gram-negatives, because of aspiration mainly. In COPD or smokers, strep pneumonia, H. influenzae, M. catarrhalis, and Legionella species. In severe COPD or structural problem like bronchiectasis or cystic fibrosis, Pseudomonas will be added into this picture. Legionella, of course, you have to have some form of endemic area or some epidemic that you know of. However, it can happen in immunocompromised patients. Bat droplets, histoplasma, exposure to birds, chlamydia, exposure to rabbits, tularemia, exposure to sheep, cattle, dog, Q fever, Coxiella, Southeast Asia, SARS, Middle East, the Middle East acute respiratory syndrome, and exposure to rodents, of course, like there is a risk of plague. And this is in rural southwest United States. Now, 20% of severe community-acquired pneumonia is polymicrobial. Now, we tend to narrow our antibiotic treatment based on the cultures, but really keep in mind there is a possibility of polymicrobial infection. Now, the other problem is when you send for cultures, blood culture or sputum or anything, 50 to 60% you don't get a diagnosis. So that's a huge number. So most of the time we treat blindly. Now, personal habits. Alcohol, as we mentioned, it increases the risk of pneumonia by the fact it increases the risk of aspiration. However, if you quit drinking, you are at more risk of pneumonia for several months after quitting. So it seems it affected the immune system. Same thing smoking, as we said, like it does increase the interaction between strep pneumonia and H. influenzae with the epithelial cells, but at the same time it impaired the ciliary movements. So now to conclude with microbiology, what is the difference between ventilator-associated pneumonia, healthcare-associated pneumonia, and hospital-acquired pneumonia from microbiologic standpoint? Because most of the time we don't know the bug and we have to treat empirically. In ventilator-associated pneumonia, it is usually complex situation where you have multi-drug resistant bugs And usually these bugs are the bugs of your institute, of your ICU. Because patients in the ICU tend to colonize their mucosa with bugs that they are not used to. So you have to cover for MRSA and for Pseudomonas. But not only those, for basically almost everything. And you have to do your best to get some microbiologic diagnosis in ventilator-associated pneumonia. Now, in hospital-acquired pneumonia, it's kind of a little bit different. Although we tend to treat by the same medications, but really in reality it's a little bit different. People who develop hospital-acquired pneumonia within 5 days of admission, like of course between 2 to 5, because the first 2 days is still considered community-acquired, so between 2 to 5 days, tend to have bugs similar to that in the community. So if the patient has a mild disease and you don't want to treat aggressively with vancomycin and whatever, you still can treat with antibiotics similar to community-acquired pneumonia. Now, if you develop hospital-acquired pneumonia after 5 days, you will have a chance to have bugs similar to ventilator-associated pneumonia. That is the bugs present in the hospital. However, this demarcation of 5 days is less distinct. I mean, you can miss. So basically, you depend in your decision on the severity of the condition, plus whether you want to use like a lot of antibiotics or kind of try something less broad. Now, with healthcare-associated pneumonia and patients with nursing home, surprisingly, the epidemiology of it in patients who are in nursing home, who are ambulatory, who can take care of most of their daily activity, they tend to have bugs similar to community-acquired pneumonia. But patients in nursing home who are bedridden, who come in and out of the hospital with a lot of antibiotic exposure, tend to have bugs similar to ventilator-associated pneumonia. So that also may play in making decisions, especially if you have drug allergies or renal failure or something you can't use vanc. Now, clinical presentation, and I think this is the most important slide in the lecture. And I say this because we have so many admissions from the ER with the diagnosis of pneumonia that they don't have pneumonia. I mean, pseudopneumonia. It's not pseudomonas, it's truly pseudopneumonia. So you have to have some clinical findings in addition to radiologic findings, right? So fever, but the downside of fever, it is not present in 30 to 40% of older patients. Now, cough is present in 90% of patients. Sputum production 66, dyspnea 66, thoracic chest pain 50, hemoptysis 15. So if you don't have all of these, it's probably unlikely. But if you have all of these, and in addition to crackles, all of these findings, in addition to some crackles on exam, the chances you are truly dealing with pneumonia is 50 to 80%. So the bottom line is clinical signs alone is not enough to diagnose pneumonia. You have to have some radiologic finding. Yes, sir?
So like we get a lot of these patients who don't have radiological signs yet. We call them possible pneumonia or early pneumonia.
Okay, that's a very good question, which is in fact the last line. If you have someone who's elderly, which you think he had some, he may not be able to mount good immune response, and especially if he's altered, so he can't give you history, then if you miss pneumonia, you increase the risk of mortality. But if you have someone who is young and there is some X-ray changes and the ER doc tells you he had pneumonia based on just some X-ray finding, and you go ask him and he doesn't have all these symptoms and he's vitally stable, probably you have to look for another reason. Now, sometimes the dust is not settled yet on the case and you have to admit him with some antibiotics, but keep your mind open. Keep thinking, am I missing something else? Because there are so many things can give you similar presentation. Whether it is PE or ARDS or allergic bronchopulmonary aspergillosis or anything that can give you infiltrate or BOOP, any of that of this differential.
But if there's no infiltrate, then what?
Then you may be dealing with bronchitis. However, if you have temperature of 38.5 or above, then you really put a question mark about the diagnosis of bronchitis. Bronchitis not necessarily, most of the time doesn't give high fever. Okay, so maybe you are dealing with this. Now, CT scan is very sensitive and can tell you the diagnosis, but it is not recommended just because you are not sure. Okay, because it's too expensive and you will do a lot of them if you do that. But if you are stuck in a corner where you need to know your answer, then CT scan probably will give you some answer when you don't have X-ray changes.
How long does it take for those X-ray changes to show up?
The X-ray?
How long does it take after you have pneumonia? How long does it take for you to see them on the X-ray?
Now, of course, it depends on how bad is the pneumonia, but the concept, like if the patient is dehydrated and you give him fluid and the pneumonia will show, is not really valid. However, early pneumonia, patients who had bad COPD and a lot of bully, who are obese, you probably won't see it well on chest X-ray. And in this case, you have to keep your mind open. And again, that is the problem with pneumonia. You admit a lot of patients with presumed pneumonia, and then it turned to be something else. And that is really the point of this slide. Try to keep your mind open. If you don't have the classic symptoms and signs, probably I'm dealing with something else. Give them antibiotic, okay, for the first day or two till you find out, but keep your mind open. Now, one thing about this is tachypnea. Tachypnea is the most sensitive sign of pneumonia. It's not specific at all, but it is the most sensitive. If you see someone without tachypnea, also you question the diagnosis of pneumonia. It usually starts 1 to 2 days before presentation or before classic signs and symptoms of pneumonia. And really it helps, tachypnea. And I can tell you a story from a couple weeks ago. A patient was going to be admitted for sepsis because of hypotension and some X-ray finding. He doesn't have all of these symptoms. It turned to be he had acute renal failure from benign prostatic hyperplasia, and he's on chronic morphine, high doses of morphine for back pain. So he ended up with like as if narcotic overdose from the renal failure. So he had this hypotension and little bit of somnolence, but it wasn't infection at all. And he didn't have tachypnea, no white count, no fever. And again, he was not elderly too. Now, these are the bases of the disaster we are dealing with. Why we are admitting a lot of patients with pneumonia, and then they turn to be not a pneumonia, why they don't get a proper full workup in the ER. This was from data in 2004, and if you see 30 days mortality, in hospital mortality, length of stay, and 30 days readmission rate, all favor patients who get antibiotics within 4 hours. However, the difference, as you see, is not very significant. In fact, in hospital mortality, it is not even statistically significant. That is line number 2. Okay? Now, this data come up, and then Medicare rule came up that you have to give antibiotic within 4 hours. And of course, he will get admitted with pneumonia, and this was the result. Increased percentage of patients who receive antibiotics. Increased percentage of patients diagnosed with community-acquired pneumonia without X-ray abnormalities, like you mentioned. Increase the percentage of blood culture orders. Final diagnosis of community-acquired pneumonia, in fact, went down. And mean antibiotic utilization went up. There was no difference in pneumonia severity index, in CURB 65, or in mortality. So we end up spending more without much benefit. Now, this term, typical versus atypical pneumonia, we use it all the time. However, it's not recommended to be used anymore. What does it mean, typical? You can call it typical presentation, or you can call it typical bug. The bugs are usually strep pneumonia, H. influenza, Klebsiella pneumonia. Usually it is acute with fever, cough, productive, consolidation on physical exam or X-ray. The atypical ones, like chlamydia or coxiella or legionella, they usually tend to have more of a close to normal white count. It is less acute, the fever is less severe. However, the distinction, whether based on clinical or radiologic findings, is not sensitive or specific enough. And that is a difference between the recommendation of the ATS versus the European Society. Here we treat community-acquired pneumonia for strep pneumonia and atypicals, while in Europe they treat for strep pneumonia and they add atypical coverage only if there is signs and symptoms or radiologic finding to suggest atypical infection. Okay, so just don't use it, it doesn't matter. Now, biomarkers. This is a new field and it is really getting more and more, these biomarkers. And there are maybe 10 or 15 more than these biomarkers I mentioned here. These are the ones that I think maybe you get asked on, which is SID rate, admission platelets, procalcitonin level, admission BMP, and admission blood sugar. However, again, there are several. It's related to amyloid, CD markers, interleukins, and all either under investigation or the clinical value is not proven yet. So what is a procalcitonin? It's of course the precursor of calcitonin. It increases in anything that induce leukocytes, whether it's infection, trauma, burn, or even neuroendocrine tumor. First, when it came out, they thought like it will be a very helpful tool in differentiating viral from bacterial pneumonia. But it seems it is not that helpful, and it is not used for this purpose anymore. But it still has its use. It can help you evaluate the severity, prognosis, or progression of pneumonia. So the patient comes with certain value. If the value gets worse, then probably your patient is getting worse. If it is getting better, then probably he is getting better. There was a study comparing using antibiotics based on calcitonin level versus based on clinical judgment. It tend to be patients who had who are the procalcitonin group has less antibiotics, less side effect from antibiotics, but equivalent outcome. So really that is the only proven benefit for calcitonin, is to follow up your patient, just like ESR. And this is one of the studies on it. Basically, it tells you the time was less and the number of days on antibiotics was less. Now, platelets. Surprisingly, look at this graph. It's really very interesting. Platelets help in identifying prognosis, while white cell counts doesn't help much. So if you have patient who presents with thrombocytopenia or thrombocytosis, their mortality is higher. While patients who present with leukocytosis, although the curve goes up a little bit, but it is not that much, not that significant. The platelet count is very significant U-shape. If it is low or high, it is bad. And this is the admission platelet, not the subsequent platelets when you start giving medicine and the platelets can drop because of this. Admission hypoglycemia is also another marker. If patient comes to you with blood sugar less than 72, he's at higher risk of 30-day and 1-year mortality. In fact, in hospital mortality too. And it makes sense. Patient who comes with infection and hypoglycemia, it means he doesn't have good glycogen reserve in his liver to preserve his blood sugar. Usually when you are stressed, your blood sugar goes up, not down. So if he doesn't have that reserve, probably he is very weak and he may have high risk of mortality. And interestingly, apart from this topic, if you have elderly patient who had pneumonia and you treat him and he's doing well, and he went home. The all-cause mortality of this patient, and I'm talking about elderly with regular pneumonia, the all-cause mortality within a year is close to 50%. So when he starts developing pneumonia from his normal oral flora, that means his system is getting weaker and weaker, and his all-cause mortality will be higher. Again, back to the concept that it is aspiration is the main problem, the microaspiration. Now, of course, yes, sir.
You're talking about procalcitonin levels. Why is it that when there's an increase in, we get that the neuroendocrine cells of the lung is causing the procalcitonin levels to go up as a pro-inflammatory marker?
Not necessarily from the lung. I don't know where it's coming from, but it can well be coming from the white cells or bone marrow.
But why is it not causing a corresponding increase in calcitonin levels or a decrease in calcium when they measure this on patients?
I don't think I came across an answer to this, but I think the calcium homeostasis is so delicately controlled, and calcitonin has no big impact on calcium, not like other hormones. So probably that's why. Or maybe there is another step that converts procalcitonin to calcitonin that needs the calcium. But I don't think I came across the mechanism for it exactly. Now, hypocapnia and hypercapnia on admission is also another marker, and it's self-explanatory. If he's hypocapnic, then he's tachypnic. And if he is tachypnic, up to the point he is washing out his CO2, that means he's heading towards sepsis. So his mortality is more. And if he's hypocapnic, that means he's weak and he's unable to keep up. So he's getting hypercapnic. His ventilation is getting impaired, which also it means a severe disease. Another marker is pro-BNP on admission. Pro-BNP, when it is high, that means your heart is stressed. And I think it makes sense. That means there is increased risk of mortality. Now, limitations of chest X-ray. There is inter-observer variability. It is suboptimal specificity. Like we said, there are several things can look like infiltrate. Sensitivity decrease in patients with emphysema, biliary structural abnormalities, obesity, early infection, and profound leukopenia, granulocytopenia. Now, there is another thing about radiologic patterns. They used to say this radiologic pattern may mean typical, atypical, fungal. It is not very accurate, really. So don't depend, like we said, on radiologic pattern. Sputum exam. Sputum exam, really, it's a helpful tool if we know how to read it. And there are 2 points you have to check before looking at the results of the sputum exam. And these points to make sure whether your sputum exam is valid or not. Like to even look at it from the beginning. You have to determine, is this a valid sputum exam? So I have to make sure there is few or no squamous cells, because squamous cells come from the mouth. There is no squamous cells in the respiratory mucosa. So if I have squamous cells more than 10 per low power field, I have to discard this sputum exam. I wouldn't care about it. The other thing is I have to see a lot of white cells in the sputum. I have to see more than 25 white cells per high power field. If I have these 2 points in my sputum exam, then I can make use of it. Otherwise, it's useless. Now, how often we get this good of sputum sample? It's probably 40% or less. We get good sputum sample. So the specificity of a gram stain of a valid sputum sample for strep pneumonia is more than 80%. Now, the problem with strep pneumonia and H. influenzae, it is a fastidious organism, so it dies easily. So sometimes you see it on the gram stain, but you don't culture it. Okay? So that is okay with strep pneumonia and H. influenzae. However, in other gram negatives like E. coli or Klebsiella or in staph, these are hardier organisms. And they tend to proliferate in the sample itself or during processing while you transfer your sample. So if you see it in the sputum, it doesn't mean you have a gram-negative or staph pneumonia. But if you don't see it, probably you don't have it. You don't have the pneumonia due to those. Okay? So that's the difference between those two. So staph and gram-negative bacilli are hardier and can proliferate during sample transport, and therefore true pneumonia due to these agents is doubtful if the gram stain of a valid sputum sample does not show the presence of these bacteria. Very important point. In the absence of informative gram stain, the predictive value of sputum culture is very low. Like if I didn't find anything on my gram stain, but the culture grew strep pneumonia, probably I'm dealing with something different. Okay, so I have to look at at the validity first, gram stain next, and culture third, like the order of importance. If I find one single bug on gram stain, or a predominant one, more than 90%, this is considered diagnostic. It's also helpful. So gram stain culture had good sensitivity, however the specificity is poor and cannot differentiate colonization from infection, or cannot differentiate even oral contamination. Because as we say, pneumonia is from aspiration, so oral contamination changes it completely. Culture of expectorated sputum is not appropriate for the diagnosis of anaerobes because the mouth has a lot of anaerobes. So if you want to check for anaerobes, you have to do bronch and aspiration from inside. It's also something to keep in mind. What about blood and pleural fluid culture? The yield is less than 20% of them. We still do them most of the time, but it has very low yield. If it is positive, it is diagnostic. Now, about pleural effusion, 40% of patients with pneumonia do have exudative effusion, but very few of them have empyema. It is just parapneumonic effusion. Now, when do we tap it? When it is large. If it's a little bit, just obliteration of an angle, you can just monitor it, but you have to monitor it. The third tool is antigen detection, specifically for strep pneumonia and Legionella pneumonia, serotype, serogroup 1, and this is basically the urine antigen detection. And it's helpful because it can give you a result within an hour. It has decent sensitivity and very good specificity for both. And it can remain positive for several weeks. Now, this was, I think, a question in MCSAB. When do we get blood culture, sputum culture, and urine antigens? If you are dealing with pneumonia on outpatient base, you don't have to order any of them. If you are dealing with patients in the ICU or any of the other conditions listed here, then you have to get them. Any patient in between, that is, get admitted to the hospital but doesn't have any of these conditions, based on the ATS and the Infectious Disease Society of America, it's up to you. You may or may not. However, for blood culture, it is a Medicare requirement to get blood culture before the first dose of antibiotic within 4 hours. Otherwise, the hospital gets penalized. Usually this gets done by the ED staff, and it gets done very well. But really, this is a very important point. If you have someone who is sick or has one of these conditions, you need to order all three. If you have someone on outpatient base, you don't need to order any. That's the message. Yes, sir.
I think that core variant is going away this year.
I'm sorry?
That core variant you're talking about, the blood cultures,
The-
that is going away this year because the Medicare thinks, okay, now everybody's doing whatever they're supposed to do.
Probably all right, but to my knowledge, it's still valid till now. I don't know if it's gone yet or not.
Most of them are going away. There may be a couple of things they're going to be there, but that's what Michelle told us.
Oh, I hope, really. So what are these conditions? Of course, ICU admission, failure of outpatient antibiotic, cavities, leukopenia, alcohol, severe liver disease, severe structural lung disease, asplenia, recent travel, positive Legionella or Streptococcus urine antigen detection, and pleural effusion. So basically, if you have doubt, order them. That's the bottom line. What other tests do we have that can be helpful? PCR, generally for atypicals. It's also helpful for viruses. Serologic evaluation, we usually order Mycoplasma, IgM, and IgG. It's helpful from epidemiologic standpoint. It doesn't help your patients. It will be positive at least in 2 weeks. So it's not very helpful. There is another one, specific fluorescent antibodies for evaluation of sputum sample. It's biggie in Legionella pneumonia. Now, Legionella pneumonia is the most common of the atypicals. Now, there are other bugs that this technique can be used. The benefit of it, it can give you quick diagnosis. Just sputum and fluorescent stain, and then you can get your diagnosis. Now, bronchoscopy. When do we do bronchoscopy? For me, as a fellow on every patient. No, I'm joking. So if you have life-threatening community-acquired pneumonia, who you really need to have a diagnostic material. If you have progressive pneumonia despite proper antibiotic use, if you have immunocompromised patient, and if you have health or hospital-acquired pneumonia, especially ventilator-associated pneumonia. In these cases, you need to do bronch because you need to do your best to identify this bug if you can. Now, this last paragraph, I think it's important. It's back to your question, in fact. When you have someone in the ICU and he developed new infiltrate, or he developed new leukocytosis, or he developed fever, none of them, or develop new radiologic finding, none of these things are sensitive or specific enough to tell you this is a healthcare-associated pneumonia or ventilator-associated pneumonia. You need some definite microbiologic diagnosis because patients in the ICU can have PE, can have ARDS, can have atelectasis, pulmonary hemorrhage. All of them can present, basically everything can present like everything. So you need microbiologic diagnosis, that's why. So basically the bottom line, I have someone who has severe disease, life-threatening disease, or immunocompromised. What is the advantage of bronchoscopy versus expectorated sputum, or the differences? It has improved sensitivity, especially for bugs like mycobacteria or fungal, because these bugs, once you see it, you get your diagnosis. Now, not all of them. Atypical mycobacterium, no, there are certain criteria to diagnose it. But there are certain, like if you have Mycobacterium TB or you find intracellular fungus, then probably you got your diagnosis. So it is sensitive. It is more sensitive, you get a deeper sample. But the specificity is not good. It is just like the sputum. Why? Because of oral contamination. So how do we solve it? How can we get better specificity? By doing quantitative culture. So what we do when we do the bronchoalveolar lavage or we do the protected sheet brushing, we send for quantitative culture. And it is just like the urine exam. If you have colony forming unit more than 10 to the power 3, then probably you are dealing with a true diagnosis. So it is just like urine exam. You send for colony count. Okay? Now it's also helpful to identify anaerobes because you will bypass your oral mucosa. BAL can exclude infection when cultures are negative, however sensitivity reduced by prior antibiotic use. And I haven't seen someone who do bronch before giving antibiotic. So really that point is not very valid. Contaminated BAL specimen is identified if you have epithelial cells more than 1%. Like we say in sputum sample, you have to have it more than 10 per loaf power field. Here you have to have more than 1% to call it contaminated. Now, BAL can give you immediate diagnosis if you have white cells with 2 to 5% of your white cells has bacteria within it. That immediately tells you are dealing with pneumonia. So there are some advantages of bronchoscopy versus sputum sample. However, look at these new studies. They compared BAL or protected sheet brushing, like quantitative cultures versus qualitative endobronchial aspirate. And they found in the first group, you have less hospital stay, less antibiotic use, and better mortality. Okay? But when they compared endobronchial aspirate quantitative cultures with BAL quantitative cultures, the results were the same. So basically, if you have someone in the ICU who you want to have a sample, you don't have to bronch him. You can just put a tube in, flush some saline and aspirate it back and send it. It will be as good as BAL, but you have to send it for quantitative culture rather than qualitative. Now, this is a case to switch gear to identifying severity and for disposition of patients, proper disposition. We have a 70-year-old man is evaluated in the emergency department for acute onset of fever, cough, which is productive of yellow sputum, right-sided pleuritic chest pain, and dizziness. He had history of diabetes and hypertension, treated with hydrochlorothiazide, lisinopril, glyburide, and metformin. On physical examination, his temperature was 35, blood pressure was 110/70, pulse rate 120, and respiratory rate of 36. He appears to be in acute respiratory distress. Pulmonary examination reveals dullness to percussion, increased fremitus, and crackles to the right lung base. He is oriented only to person. He had severe leukocytosis, platelet counts is reasonable, BUN is elevated, and creatinine is elevated. He's hypoxic, and he is probably tachypnic, like we know. His PCO2 is low, and he had infiltrate on the chest X-ray. So, where do you admit him? Of course, ICU. Now, what if we say the same case without confusion? Where do you admit him? Now, the CURB 65 score will go down by 1 point, but probably also ICU. No, probably is also ICU, and that is the reason why. We have two tools to assess severity. The pneumonia severity index and the CURB 65. The pneumonia severity index is complex, and you probably need some software or MedCalc or something to calculate it. While CURB 65 is easier. They are both valid, but both has limitations. The studies on them were based on mortality. So this is the main outcome of these two score systems, is mortality. There's nothing else but mortality. So it was not originally made for disposition of patients. So if you have high CURB 65, of course you have higher mortality. But it doesn't tell you whether you should send them to ICU or you should send them to the floor. Although the current recommendations, at least they say if you have 0 to 1, you can send them home. If you have 4 to 5, you have to send them to the ICU. If you have 2 to 3, 2 either short stay or close observation outpatient, 3 inpatient. That is the general consensus. However, the point from really this lecture is don't follow this. If it's very helpful to tell you I'm going to admit or send home, but it doesn't tell you whether I should send them to the ICU versus floor. And why that is very important. Because they found patients who get admitted to the floor first and get transferred to the ICU have higher mortality than patients with the same severity who get admitted to the ICU from the beginning. Okay? So depend on curve 65 just to admit versus not, but don't depend on it to decide about ICU. There are several criteria developed to tell whether I should send the patient to the ICU or not. And this is a summary of it. Like ATS made a criteria where they said 3 points is enough to send them, but there are 4 or 5 of them. But really, the bottom line, if you have 2 or 3 points of what is listed here, is probably enough to tell that my patient needs to go to the ICU, regardless of his curve 65 score. Okay? Most of these points are logical. Most of these points are from PSI or curve 65 score. But just keep this in mind. If you are in doubt, send them to the ICU. Better mortality.
Is there anything, this is like early intubation or anything like that, has any effect on mortality?
Yes, if you are dealing with sepsis. If you think your patient is septic, early intubation help with mortality.
Because I mean, a lot of times
On what
they
basis?
do
Why would the mortality increase?
Because in sepsis, you know, now you are breathing here at rest. How much of your energy is spent for you to breathe? 5% of your basal metabolic rate, 6%, I mean, not much. If you are in sepsis and you are tachypnic to wash out your CO2 because of your lactic acidosis, 90% of your basal metabolic rate will go to your breathing. So you are unloading the respiratory muscles, quote unquote. You will keep the energy and the effort of the body for something else.
So many times the ER physicians, want to just say, we'll try them on BiPAP and see how they do. And, there's this whole early initiation of sepsis now in the ER as a core measure with aggressive fluid resuscitation. And, I just wonder if we'll start to see more early intubations. Because a lot of the trend is to try them on BiPAP and let them go to the ICU and they crash. And, you always wonder if you early...
Absolutely true. Absolutely true. In fact, we had a patient just yesterday. He came to the ICU and he was gasping. But early intubation definitely has better mortality in sepsis, for sure. I mean, this is proven.
Yeah, that's the thing. You just try to
Nobody will blame you if you intubate sepsis patient. Nobody. So anyway, keep these criteria in mind. It's very helpful to tell if you want to admit your patient to the ICU. Now, selection of antibiotic agents. There are several factors we have to think of before selecting antibiotic agent. First, the setting we are dealing with. Are we dealing with community-acquired, ventilator-associated, health care associated, or hospital acquired? That tells you the epidemiology. So the epidemiology is one big circle. Now, the other big circle is my patient, how my patient look like. How old is he? How severe is the illness? Is he immunocompromised or not? Did he get antibiotics or not? And then the third circle is, can I tell which bug am I dealing with based on some history or physical exam, like some extrapulmonary manifestations? They are rare. I'm not sure you are going to get it in questions, but something like bullous meningitis or pericarditis or things of that, or hemolytic anemia, all associated with mycoplasma pneumonia. So the empiric coverage for community-acquired pneumonia, as all of you know, I'm sure, it's second or third generation cephalosporin plus macrolide or respiratory fluoroquinolone. This has to be based also on epidemiology. If you know there is epidemics, you may change it. If you think there is TB, try to avoid fluoroquinolone. This induced resistance. If you want to use macrolide, don't use macrolide alone. There is also significant increased resistance. However, there is a study about older patients. They found regimens that has macrolide in it associated with better 90 days mortality. So if you want to use, probably macrolide is good if you use it in combination, especially in elderly. And I don't know why they stress this point. For ventilator-associated pneumonia, this is kind of important, of course. We have to cover for MRSA, for Pseudomonas, by double coverage. So we end up with something like Vanc, Zosyn, and amikacin. That's the most usual three we use in ventilator-associated pneumonia. But the second point, the hospital-acquired pneumonia, I think we overdo it. We have to look at this. Monotherapy is probably enough in patients who didn't receive antibiotic before or doesn't have other risk factors. So really, you don't need to cover for staph, for MRSA, in healthcare-associated pneumonia, unless you had really skin infection or wound or prior history of MRSA. Okay? For HCAP, it's difficult to tell because, like we say, if they are ambulatory, they are similar to community acquired. If they are not, then probably they are similar to VAP. So how do we deal with it? In someone who comes from nursing home, hit hard, but once the culture comes back negative, stop the broad spectrum antibiotic, downgrade it to community acquired coverage. And they say this is associated with better outcome. So this is a potential question. Okay? Once your culture is negative, downgrade it. Especially in healthcare associated. Yes, sir?
So people that have risk factors for HCAP, but they're not that sick, do you have to use the vancomycin?
No. If you have mild to moderate disease, you can use single agent, and the single agent can be Levaquin or ceftriaxone or something like Zosyn. You can use single agent. If you have severe disease and you think it is healthcare associated, but there is no risk for MRSA, use double gram-negative coverage. Like use something like Zosyn or carbapenem, and then add something like amikacin or Levaquin. If you are dealing with severe disease with no MRSA risk. However, if there is a skin infection, open wounds, or whatever, try to add MRSA coverage. But this is not in ventilator associated. In ventilator associated, add MRSA coverage to all. Now, I think we talked about this. Last two slides about prevention. We have pneumonia vaccine, you have inactivated vaccine, and you have the life attenuated vaccine. The inactivated vaccine is to everybody above 6 months old yearly. The life attenuated patients has to be healthy, has to be between 5 to 49, and they have to be not pregnant, not immunocompromised, and not a healthcare worker. You don't want to transmit this bug. It is life attenuated. Pneumococcal vaccine, this is relatively new information. I think it's 2014. You have the purified polysaccharide vaccine, the PPSV23, that is the old one. And then you have the newer one, the pneumococcal conjugated vaccine, that is the PCV13. The difference between them, the first one is broader. It can cover 23 serotypes. The other one is 13. However, the first one gives you antibody for 4 to 7 years, while the second one gives you kind of close to lifelong immunity. So how do we apply those? We used to do patients above 65, we vaccinate them with the first one every 5 years. And then they came down to patients who are above 19 years old to 64 with any respiratory illness, or smokers, like risk of pneumonia. You have to give them the 23 one, the first one, every 5 years. And then when the stronger one came out, they decided patients who had significant disease like HIV or asplenia or significantly immunocompromised, they start using the PCV13 on all patients above 19 years old. But currently, in fact, after 2014, the ACIP recommendation is to use both to everybody who is above 65. And this is a question in the VA because this came to the VA lately. So how do we do it? We use the PCV13, and then 1 year later, we use 6 months to 1 year later, we use the older one. Or if the patient had the older one, wait 1 year and use the newer one. So now the current recommendation, anybody above 65, you can use both. Okay? And that is the hour. Any questions?
How about younger people with the chronic respiratory illnesses?
Chronic respiratory illnesses, that is not like HIV or asplenia or like something like just smoker or mild COPD. There is no guideline yet to use both, at least to my knowledge. The newer one, you use it first, and then you use the older one 1 year later. Okay? Thank you.